Cái đấy em coi kết quả sao đó.
Thì, bác sĩ kêu tới tới ăn này tôi chết mà bây giờ
Hello, Mr. Kok. How are you?
Hello, Irma. How are
How
you?
are you? Good, good. Long time no see.
Oh, wow. Oh,
Hello,
hello.
good
How are
to
you, Mr. Lok?
hear
Congratulations
me.
on being out here.
Yeah,
On the good,
See you.
three members there. Thank you.
Yes.
yeah. Thank you for your time.
Thank you.
See you later.
See you, see you. Are you on duty?
mandi nak. Pakai baju kaki tangan dia nak ya. Ada udah janji sama ayah.
Yes, a very warm welcome to everyone joining us from Indonesia, across Asia, and to all our colleagues and friends all around the world. Welcome to the CPD Asia. This is the online continuing professional development platform for Asian Radiologic Technology Societies dedicated to learning, collaboration, and professional growth beyond borders. And tonight, hosting the 64th CPD Asia is the Perhimpunan Radiografer Indonesia, PARI. I am Peachy Luna, CPD Asia Secretary General, and I'm truly honored to be your CPD Asia program host. So to everyone watching, we are live streaming on YouTube. You can search PARI, P-A-R-I, or VART, V-A-R-T channels, so you can join us live or watch a replay at your convenience. This CPD Asia program is highly supported and graciously graced by our member societies represented by their presidents, officers, and official representatives. With great respect, may we acknowledge and warmly welcome President Fernando Koch of Macau Radiological Technologists Association.
Hello, good evening, everyone. I am Fernando from Macau. So happy to see you again. Thank you.
Thank you, sir. We also have President Mr. Taiwan Loc of Vietnam Association of Radiological Technologists.
Good evening, everyone. I'm Loc. Congratulations, Indonesia. Thank you, Vichy. Thank you.
Thank you always. Also, we have President of Malaysian Society of Radiographers, President Sawal Marsait.
Hello, everyone. Good evening. Thank you for the hosting the webinar. Thank you.
Yes, thank you, dear sir. Representing Taiwan Association of Medical Radiation Technologists, Miss Alice Chang.
Good evening, everyone. I'm from TMRT, and thank you.
Yes, thank you, Miss Alice. And we also are thankful and grateful to the greetings that we have received from President of Hong Kong Radiographers Association, President Mr. Nang Tat Ming, to President of Singapore Society of Radiographers, President Haris Abdul Razak. Also from Indian Society of Radiographers and Technologists, President Mr. Mohan Lal Bhagwat. And I think we have here live is President Vitarana Gamejri Malasen of Society of Radiological Technology, Sri Lanka. Dear sir.
Hello, good evening. Thank you, Pichi. Congratulations, Indonesia. Welcome all of you. Thank you. Thank you very much. Okay.
Thank you, sir. Very quickly, President Nan Tat Ming is also here live with us.
Hi, everyone. Good evening. Nice to meet you again. Enjoy to like the program. Thank you.
Thank you, dear sir. Again, we also have received warm greetings from President Sophie Lee of Association of Cambodian Radiological Technologists, from President Katsuhiko Ueda of Japan Association of Radiological Technologists, from President Koi Wei Wu of Taiwan Society of Radiological Technologists, and also from President of Hong Kong Association of Radiation Therapists, HKART, Dr. Vincent Leong, from President of Philippine Association of Radiological Technologists, PART, President Ruben Lorenzo. And I see joining us also is Ma'am Cora Nang, Mr. Puto Adi Susanta, yes, as our invite, Mr. Sivila Intenseng from Lao, and we also have Putu Irma joining us as one of our panelists. May I humbly request everyone to please open your camera for a very short photo opportunity. All right, so they'll be joining us again later for the Q&A session. Now, to formally open our program, may I kindly request, dear Sir, President of Perhimpunan Radiografer Indonesia, President Dr. Gek Sugianto, to give us a very warm welcome.
Okay, thank you, Pichi. Good afternoon, ladies and gentlemen, esteemed colleagues and friends from across Asia. Distinguished President of Radiographer Association throughout Asia, keynote speakers, Mr. Hidayat, Agus Sabarudin, Mr. Ahmad Subarkah, and all esteemed participants joining us today from throughout Asia. On behalf of Indonesian Society of Radiographers, PARI, it is my absolute honor and privilege to welcome you all to the 64th CPD Asia webinar. PARI is deeply proud to host this valuable international platform once again, fostering continuous learning and professional collaboration in medical imaging. Dear colleagues, pulmonary tuberculosis remains a critical public health challenge worldwide, particularly across many regions in Asia. In the diagnostic journey of TB, radiographers stand at the forefront, serving as the vital link between advanced technology, precise imaging, and patient care. Tonight's themes: single disease, 3 imaging modalities, 1 radiographer's perspective, highlight the core of modern medical imaging practice. We thanks to distinguished expert, Mr. Hidayat Agus Sabarudin and Mr. Ahmad Subarkah, who will share their knowledge to us in this evening. I encourage all participants to take full advantages of this session, engage actively in the discussion, and take away practical insight that can elevate clinical practices in your respective institution. Ladies and gentlemen, I would like to extend my heartfelt gratitude to the CPD Asia Committee, the organizing team, our speakers, and every participant for your dedication and professional excellence. Your commitment to lifelong learning is what continues to elevate the standard of radiography across Asia. It is now my great honor to officially open the 64th CPD Asia webinar. Thank you. Have a highly fruitful webinar and enjoy the session. Thank you.
Thank you very much, President of Perhimpunan Radiographer Indonesia, President Dr. Gek Subianto, for that very warm welcome. So now, without further ado, allow me to introduce our session moderator. Ms. Pamela Puspa, Master of Diagnostic Imaging Science, is a sonographer and academic with a background in radiology and expertise in ultrasonography and diagnostic imaging. She has experience as a sonographer and is actively involved in education and healthcare development. She is also the innovator behind the DRU-PADI, Deteksi Resiki Utama pada Kanker Payudara Dini, an initiative focusing on breast cancer screening, health education, and early detection awareness. Please welcome our session moderator, Ms. Pamela Puspa. Hi, Pamela.
Hi, Pichiluna. Hello. Thank you very much for Miss Pichiluna for this very nice opportunity in this lovely occasion. It's great to see you again. Okay, dear ladies and gentlemen, now we are entering our first scientific session. And before the presentation, let us first get to know about our first speaker through a short profile video. And our first speaker is Mr. Hidayat Agus Sabarudin, a radiology professional with extensive experience in medical imaging technology, computer tomography, education, innovation, and radiographer professional development. And to learn more about his professional background and journey, let us watch this profile video.
Of experience is medical imaging technology development, education, innovation, and healthcare quality improvement. His career began as a radiographer in 1996 and progressively developed through various strategic positions at Siemens Healthineers Indonesia, including CT radiographers, CT application specialist, CT account manager, Head of CT Product Specialist, Business Manager for CT and Molecular Imaging, and Call Development and Training Center Manager. In professional organization, he previously served as a head of the Standardization Division at the Indonesian Health Profession Council from 2022 to 2024. He currently serves as a chair of College of Radiographer at the Indonesian Health Council, a position he has held since 2024, where he leads the development of professional competency standards, curricula, and certification for radiographer. He also recognized as the developer of ASHR, Alih Suara Hasil Radiologi, an artificial intelligence-based innovation designed to support digital transformation in the field of radiology. With extensive experience spanning clinical practice, industry, education, and professional development, he has strong expertise in computer tomography, digital transformation, and the advance of the radiographer profession.
Okay, thank you for the profile video of Mr. Hidayat Agus Sabarudin. Dear ladies and gentlemen, now we will proceed the presentation which entitled From Chest X-ray to CT Thorax, Imaging Pathway in Pulmonary TB. So Mr. Hidayat Agus Sabarudin, I believe this floor is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone, and a warm welcome to our colleagues joining from across the ASEAN region and beyond. It is an honor to be here today for the 64th webinar CPD Asia, hosted by the Indonesian Society of Radiographers. And my name is Hidayat Agus Sabarudin, now as chair of the Radiographer College in Indonesian Health Council. I'm pleased to share our professional perspective on the imaging diagnostic pathway of pulmonary tuberculosis or TB. Tuberculosis remains one of the world's greatest challenges in terms of infectious disease. According to the Global Tuberculosis Report 2025 from World Health Organization or WHO, an estimated 10.7 million people developed TB in 2024, and 1.23 million people died from the preventable and curable disease. One of the most important message from this report that just 8 countries account for 67% of the global TB burden. Among them, Indonesia ranks second after India, with an estimated 1.08 million TB cases, contributing approximately 10% of all TB cases worldwide. This highlights the critical role that Indonesia, together with other ASEAN countries, plays in achieving global TB elimination. Another major challenge is the diagnostic gap. While 10.7 million people were estimated to have TB, only 8.3 million cases were officially notified, meaning millions remain undiagnosed or untreated, allowing transmission to continue within communities. Drug-resistant TB also remains a significant concern, with 390,000 MDR-RR-TB cases reported globally. Although treatment outcomes continue to improve, many patients still do not receive timely diagnosis and care. This finding reminds us that ending TB requires more than effective medicine. It requires strong political commitment from country, from government, early detection, and quality diagnostic services. And in this regard, radiographers or radiological technologies will play a crucial role, particularly in early detection through TB screening programs, especially in Indonesia. According to the Global Tuberculosis Report 2025 from WHO, Indonesia remains the second highest TB burden country in the world, with an estimated 1.08 million TB cases in 2024, including approximately 26,000 MDR TB cases. Indonesia notified 856,420 TB cases, achieving 77% case detection coverage. While reflect significant progress, nearly 1 in 4 estimated TB cases remain undetected, emphasizing the need to strengthen early case finding. The treatment success has reached 86% for drug susceptible TB and 59% for drug resistant TB. Although encouraging, improving outcomes for MDR TB remain a priority. The disease affects all population groups. Men account for 49% of cases, women 34%, and children under 15 years 17%. Indonesia continues to strengthen TB prevention and control through improved laboratory confirmation, active contact tracing, better MDR TB management, and stronger community engagement. Together, these efforts are essential to accelerate progress toward ending TB in Indonesia. But exactly are we looking for? TB is primarily transmitted through airborne droplet when the infectious person coughs or sneezes or singing. While pulmonary TB is the most common form, we must remember extrapulmonary TB, which can spread to the lymph node, spine, brain, or even the abdomen. In high-burden countries like Indonesia, factors such as population density and late case detection often accelerate transmission. So, early detection and appropriate management of TB are essential to break the chain of transmission and improve patient outcomes. Clinical feature. Clinically, we often see patients presenting with a persistent cough lasting more than 2 weeks, with fever, night sweat, and unexplained weight loss. As radiographers, we must recognize these red flags. Imaging is indicated not just for symptomatic patients, but also for high-risk individuals, such as close contact or those who are immunocompromised, to assess the extent of the disease and monitor treatment response. In our diagnostic toolkit, we have 3 main players in TB. One is the chest X-ray, second ultrasound, and the third is CT scan. The chest X-ray, this is our backbone. It is fast, cost-effective, and widely available. About ultrasound, is an excellent complement, particularly for evaluating pleural effusion or chest wall involvement. And the CT scan provides the highest sensitivity for early disease detection and evaluating complex complications. The right imaging modality used at the right time and for the right patient will be improved diagnostic accuracy, optimizes treatment, and reduce the transmission. The next is common imaging finding in pulmonary TB. Pulmonary TB can present with a wide spectrum of imaging finding. Number one is the consolidation. What do these pathologies look like on our monitor? We might see the consolidation typically in the upper lobe, cavitation, this a thick or thin wall, or the classic tree-in-bud appearance, signifying endobronchial spread. Other findings include like a nodule, fibrosis, or biliary TB. And the other is like a volume loss, pleural effusion, calcified granuloma, and hilum lymphadenopathy. We must remember that TB is a great mimic and can look like many other diseases. Now, Now move to the section imaging pathway. Chest X-ray. When and why? Advantages are clear. It is non-invasive and provides a quick assessment. With the portable or the mobile X-ray is enough. However, we must be mindful of its limitation, such as lower sensitivity in very early TB or paucibacillary cases. Timely execution is key to breaking the chain of transmission. Let's start with the cornerstone of our practice, the chest X-ray technique. As radiographer or radiological technologists, our primary objective is to obtain high-quality diagnostic image while ensuring the safety of patient and staff. The indication we often encounter patients with a persistent cough of over 2 weeks, those in screening programs or high-risk group such as HIV patient and close contacts. About positioning, for standard adult, the PA or posterior-anterior view is our gold standard. We want the patient standing erect, shoulder roll forward to clear the scapula, and the chin rise. If a patient is severely ill or bedridden, we move to AP, antero-posterior view. Related with the exposure parameter, we typically use a high voltage technique between 100 until 155 kVp. This is with a SID of 180 centimeter to minimize magnification the magnification. This parameter is for mobile or stationary X-ray. And for the portable X-ray, this is a different, more lower, with kVp with the QVP 70 until 90 QVP, and the SID is only 100 centimeter, or as recommended by vendor. The radiation protection and infection control, we must always follow the ALARA principle, using lead apron or thyroid collar if need. Because TB is airborne, droplet precautions are mandatory. This including the performing exam in well-ventilated room, ensuring patient wears surgical mask, and maintaining a distance over 1 meter. And don't forget, a thorough disinfection all of contact surface after every patient. Imaging pathway for CT scan. CT scan in pulmonary TB is while X-ray is our first line, the CT scan provides superior sensitivity for complex cases. It is particularly indicated when an X-ray is normal, but clinical suspicion remain high, or when evaluating complication like a pleural effusion or any abscesses. The CT scan have the high resolution imaging. We are looking for specific marker such as 3 in bath appearance. This is a suggesting for endobronchial split, thick wall cavities, or the classic miliary pattern of small, randomly distributed nodule. For parameter, for adult, we use the multi-detector CT with a helical scan mode and 120 kVp. We reconstruct a thin slice of 0.5 until 1.25 mm to capture fine detail. Our workflow here is precise, from assessing clinical indication and patient preparation, like removing metal object and jewelry, to multiplanar reconstruction like axial, coronal, and sagittal plane. Sometimes we need 3D imaging. But remember, CT is a problem-solving model. an expert or sputum smear to ensure the patient receives the right treatment. Our core principle, our role is defined by early detection, an integrated approach, and remaining patient-centered through every stage of treatment and follow-up imaging. Next, related with the using of AI or CAD integration. The new horizon looking to forward the future. AI and computer-aided diagnosis, CAD, are transforming in TB imaging, like CAD detection. This provides automated identification of nodule, cavities, and ground glass opacity, which significantly reduce the risk of misfinding. And the second is the CADX. It means this is a characterization of this help us distinguish between active TB and post-primary scarring through texture analysis. And number two, the current development in 2026, that is the automated reporting. This is related with the efficiency. We are seeing the automated reporting that can reduce radiologist workload by up to 30%. And the second is still development with AI. It's not just about interpretation, but it's about risk stratification and predicting treatment outcomes. Related with the CD from TB screening, the World Health Organization already have policy guidance and independent evaluation of CAD software at 2025. WHO now recommend CAD for individual aged 15 years old and older. It boasts high diagnostic accuracy with sensitivities of 80 until 95%. In Indonesia, our Ministry of Health has already adopted various brands like CAD for TB, Cure AI, Rayleigh, and our local innovation. The name is tbscreen.ai. The scoring system. The system provides a CAD score from 0 to 100. A score of 60 or above is highly suggestive of TB and trigger immediately molecular testing. This technology supports us as radiographers by improving the speed and consistency of screening, especially in high-volume setting. This is an example of the chest X-ray image analyzed using the CAD system. The image show and have a result like a radiology sign of TB, no, with a score 20. Opacity is observed, the pleura is normal, the heart is normal, both hilum appear normal, and the bony thorax appears unremarkable. This is automatically reporting by system. And the other image is show the radiology sign of TB, yes, with score 96%. The opacity is observed in right lung, inhomogeneous opacity, and so on. This indicating that the examination results show abnormalities and suggest that the patient has TB. Okay, this is to summarize our session today. TB remains a major global health problem, and Indonesia is a high burden country. I think after India and before Philippines. Chest X-ray is our primary modality, complemented by ultrasound for pleural disease and CT for complex assessment. Our role as radiological technologists or radiographer, we play crucial role. We are the ones responsibility for image quality, radiation safety, and strict infection control. Our technical excellence lead to timely diagnosis and better patient outcomes. And the last, CAD software application just support us and clinician to improving consistency, speed, and efficiency in TB screening. Okay, thank you very much. On behalf of Indonesian Society of Radiographers, to all of you, thank you for your attention and your participation. We are united by our core value of quality, collaboration, compassion, and excellence. Together, we are advancing radiography and enhancing patient care. Now, I'm happy to take any question you may have, and see you again. Thank you very much.
Okay, thank you very much to Mr. Hidayat Agus Sabarudin for the insightful presentation and for sharing your perspective on the imaging pathway in pulmonary tuberculosis. And we will now proceed our second scientific session. Our second speaker is Mr. Ahmad Subarkah, a professional specializing in ultrasound technology, clinical application, and healthcare product development. And before the presentation, let us watch a short video profile to introducing our second speaker.
Ahmad Subarkah is a professional sonographer specializing in ultrasound technology, clinical application, and health product development. He has building his career in diagnostic imaging since 2006. His professional journey began as a radiographer at Gedingput Hospital, where he worked from 2006 to 2010. During this period, he gained experience in diagnostic radiography, CT scan procedures, radiation safety practice, and imaging surveys within a multidisciplinary hospital environment. From 2010 to 2017, he further developed his expertise as a sonographer at Payukarta Hospital. In this role, he performed a wide range of ultrasound examination, including general imaging, obstetric and gynecology ultrasound, small parts imaging, and vascular examination. Since 2017, he has been Siemens Healthineers as an ultrasound product development specialist. In this role, he has been involved in product development, clinical application support, customer education, ultrasound solution implementation, and collaboration with healthcare professionals across various regions of Indonesia. In terms of education, he holds a Diploma 3 in Radiography from Poltekkes Semarang, followed by a Bachelor Applied Science in Radiological Technology from Poltekkes Jakarta, and a Master degree in Diagnostic Imaging from Poltekkes Kemenkes Semarang. With more than 18 years of professional experience, his career journey reflects a continuous development of expertise, progressing from clinical practice and ultrasound technology to healthcare, innovation, and product development.
Well, thank you for the profile video of Mr. Ahmad Subarkah. And ladies and gentlemen, our second presentation is entitled Thoracic Ultrasound in TB, Beyond Pleural Effusion. And Mr. Ahmad Subarkah, this time is for your presentation.
Hello, good evening to everyone joining from across Asia. My name is Ahmad Subarkah, and I work as a clinical application specialist ultrasound in one of medical imaging company in Indonesia. It is truly an honor to be invited to the CPD Asia webinar series. Today, I would like to share how lung ultrasound can contribute to tuberculosis management, not only for detecting the pleural effusion, but also for recognizing peripheral pulmonary TB and supporting safe ultrasound-guided procedures. My goal today is to provide practical knowledge that radiographers and sonographers can immediately apply in their daily clinical practice. Before we start, here is the speaker disclosure. And by the end of this session, participants should be able to understand the lung ultrasound protocol, and participants should know how to optimize ultrasound machine setting specifically for lung imaging. Third, how to recognize the common sonographic findings associated with pulmonary and pleural tuberculosis. Fourth, how to understand simple methods to estimate pleural effusion volume. And finally, appreciate the role of ultrasound guidance in improving the safety of pleural procedures. And moving forward, tuberculosis remains of the world's leading infectious diseases. Despite significant progress in diagnosis and treatment, millions of new TB cases continue to occur every year, especially in many Asian countries. While chest radiography remains the primary imaging tools, ultrasound has become increasingly valuable because it is portable, radiation-free, and can be performed at the patient bedside. As you can see here, in India and in Indonesia rank first and second in global TB burden. And this is our concern together, and to provide the good imaging to support the government to fight the tuberculosis infection. And why lung ultrasound in TB matters? Because the advantage of the lung ultrasound is no ionizing radiation, portable and bedside capable, faster density for initial screening, better sensitivity than chest X-ray for pleural fluid, and excellence for pleural procedures, useful in ICU emergency and rural setting. And for the clinical finding also, ultrasound can perform like to visualize the pleural effusion, consolidation, pneumothorax, interstitial syndrome, pulmonary TB, and can be used for guidance for thoracentesis. And the radiographer and sonographer plays a much greater role than simply operating the ultrasound machine. Our responsibilities begin with the proper patient preparation, selecting the correct scanning protocol, image optimization, and then how to do the documentation and become the assistants of ultrasound guided intervention. And the important skills that we should have is how the knowledge of lung sonoanatomy, pleural effusion identification, and how to use the needle visualization. So when scanning patient with suspected or confirmed TB, infection control must always be our first priority. proper personal protective equipment, including an N95 respirator is essential. Probe cover should be used whenever appropriate. Hand hygiene before and after every examination remains mandatory. And also ultrasound equipment and transducer should be disinfected according to the institutional protocols. And good room ventilation further reduce the risk of airborne transmission. Selecting the correct transducer greatly influences image quality. The convex probe is generally considered for lung ultrasound because it offers a good balance between penetration and field of view. The phase array probe is useful when cardiac assessment is also required, although visualization of the pleural line is usually less detailed. And the linear probe prefer transducer to evaluate the superficial lung, surface or pleural lining. Before scanning, always spend a few seconds optimizing your machine setting. Many diagnostic findings in lung ultrasound are based on artifacts rather than anatomical structures. Therefore, excessive image processing can actually reduce diagnostic accuracy. If it is possible, always use or select the lung preset or abdominal. This will optimize for the artifact. And for the frequency, as I mentioned before, for the pleura or superficial, we use the linear transducer 5 to 10 megahertz, or for the deep or for the effusion, pleural effusion, we use 2 to 5 megahertz curvilinear transducer. Optimize to visualization pleura and far field using depth, typically 10 to 15 centimeters. Adjust for the grayscale brightness, minimizing the noise. Use the focal zone, place at just below the pleural line. Use the B mode for the anatomy and M mode for the motion mode. So this is the scanning parameter from Beshara. The recommendation is, as I mentioned before, use the lung preset or abdominal or general with the tissue harmonic image and compound off. Because the dedicated lung preset typically optimize artifact visualization and reduce post-processing that can suppress the diagnostic artifact. Maintain the frame rate, if possible, more than 30 frames per second to improve the assessment of dynamic sign as lung sliding, lung pulse, and also the respiratory motion. Use the low persistent because the high persistent blurs moving structures can reduce visibility of lung sliding. And also turn off or use the minimum of the speckle reduction imaging specs, and then whatever you called it in your machine, it will be different. Speckle reduction algorithm, and then the HI, and then the compound, because may suppress the artifact and alter their appearance. And we move forward to the patient position. Whenever possible, examine the patient in the sitting position, because this allows complete access to the posterior lung field. If the patient is critically ill, scanning may be performed in the semi-recumbent or supine position. Remember that pulmonary tuberculosis most commonly affect the posterior lung, upper posterior lung. So this region should be never omitted. And we are moving forward to the scanning technique. A systematic scanning approach improves reproducibility. Begin with the anterior chest. There is like a per standard line here, and then anterior axillary line and posterior axillary line. And you can use the longitudinal or transversal intercostal view, and for the right hemithorax and left hemithorax, anterior and posterior. Maintain the probe perpendicular to the chest and move in longitudinal and transversal. Then shifting medially or laterally. And we move forward to lung ultrasound sonal anatomy. Understanding the normal lung artifact is fundamental. A-lines represent normal aerated lung. They appear as a repetitive horizontal reverberation artifact, like I point here. And also B-lines. B-lines are vertical cometal artifact. One or two isolated may be normal, but whenever it's multiple or confluent B-lines, suggest increased lung density due to the interstitial involvement. And two important signs of healthy lung are lung sliding. This is the pleural line, and when the lung is healthy, it will move whenever the patient is take a breathing. Yeah. This is the lung sliding, and this is the Cartan sign. Cartan sign occurs as an aerated lung moves over the diaphragm during the inspiration. Loss of this normal sign should prompt further evaluation for the pathology. And M mode also provides additional confirmation. Normal M mode lung demonstrate the classic seashore sign. We call it seashore because the M mode appear like this is blue sky, and then this is the sea, and this is the shore, the sand. So the normal seashore pattern of lung shows horizontal lines suggestive of the chest wall, and then the granular pattern suggestive of lungs. And when you use the M mode and you find it the sinusoid side, so in pleural effusion, sinusoid side become visible as the collapsed lung moves toward the pleural surface during the respiration. This dynamic finding increased diagnostic confidence. And pulmonary tuberculosis produce several characteristic peripheral finding. The most common is an irregular pleural line and small pleural consolidation. Larger consolidation indicated that more active disease. Apical peripheral consolidation is particularly specific for pulmonary TB. Pleural thickening and pleural effusion are also common, especially in pleural tuberculosis. This based on the Hassan Khani in Clinical Imaging Journal on this February 2026. And we move forward to the lung ultrasound sonopathology. So recognizing A lines, B lines, pleural irregularities and consolidation allows us to differentiate normal lungs from the pathological condition. Pattern recognition is the key skill in a lung ultrasound. As you can see here, this is the large consolidation, and here the small subpleural consolidation. This is the vertical artifact for B lines. This is the A lines. And another sonopathology for the lung ultrasound is MPMA. This picture, as you can see here, this is the chest X-ray, and this is a coronal chest CT image. This is the lung ultrasound grayscale and the Doppler. The Doppler image demonstrates a multicolated complex appearing fluid collection in the pleural space with septation and internal debris without internal color flow. And another one is, this is like image is confluent lines and small consolidation in COVID-19 patient. So COVID and then another infection, maybe the pneumonia, you will see the more P lines appear like this, and also this is like small consolidation also occur in TB. This is same, yeah. This is same. The clinical finding is almost same, but this example is come from the COVID-19 patient. And whenever we see the lung sliding, so the lung is healthy, but when the absence of lung sliding, it is corresponds to pneumothorax. As you can see here, there are no movement on the pleural line whenever the patient is breathing, so it is correspondent to the pneumothorax sonopathology. And we move forward to the signs of the pleural effusion in lung ultrasound. The first one is spine sign. Spine sign is the visualization of the thoracic vertebral bodies above the diaphragm due to the transmission of ultrasound through the pleural fluid. When the patient is normal, there are no pleural effusion, the spine sign would not be appear. And then this one is like jellyfish sign. Jellyfish sign is referred to the movement of atelectatic lung floating freely in pleural fluid. So this is the atelectasis, and this is the fluid, and the sign is looks like the jellyfish on the ocean. So the next one is plankton sign. This one is describe the numerous floating echogenic particles suspended within the pleural fluid. And also the septated sign refers to fibrin strands and the septa transversing the pleural space, creating the collocation within the effusion. And we move forward, and how to calculate the estimation of the volume of the pleural effusion. The Cook-2 formula is the most accurate formula within the sitting patient for the TB, pleural effusion. So the formula is estimated volume, pleural effusion volume in milliliter is diaphragm distance plus height, lung base to mid diaphragm distance, also called subpulmonary height effusion in centimeters, multiplied by 70. 70 is empirical constant derived from the original regression analysis. What if the pleural effusion is like this? Yeah? So we just add it into C plus D plus H and multiply by 70. And another measurement of pleural effusion volume, like Usta, Balik, and Eibenberger. So this one, another measurement will be used for another monitoring disease progression. And this comparison summarizes the strength of each formula. Cook-1 is simple and useful for rapid bedside estimation. However, the Cook-2 formula demonstrates the highest overall accuracy among the classic equation because it incorporates both the vertical fluid head and the subpulmonary component. The most accurate equation in predicting effusion volume is Cook-2. And this data is come from Hassan on the validation of equation for pleural effusion volume estimation 2017. And now that we have estimated the pleural effusion volume, and the next question becomes, what should we do with this information? Estimating pleural fluid volume is not the final goal. The real purpose is to support the safe clinical decision making, particularly when image-guided procedures are required. So So one of the greatest advantage of lung ultrasound is that it not only helps to diagnose the pleural effusion, but also allows us to guide the procedures in real time. So pleural aspiration, drain placement, and biopsy guidance can improve the procedural safety. As a radiographer and sonographer, our role extend far beyond the image acquisition. We contribute to the patient safety, improve procedural accuracy, facilitate the communication within the multidisciplinary team, and provide high-quality documentation that supports clinical decision-making. Ultrasound guide procedures are not one-person task. They are a team effort, and the sonographer is an essential member of that team. Now, let's apply everything we have discussed to a real clinical case. This case is coming from my colleague, Pamela Puspa. She is a sonographer at RSUD Cabang Bungin. Thanks to her providing this case. And this is a 58 years old male patient who presented with shortness of breath. His chest X-ray suggested a right-sided pleural effusion. But as we know, chest radiography cannot accurately determine the amount of fluid or identify the safest site for drainage. Lung ultrasound was performed to further evaluate the pleural space. During the examination, we assessed the characteristic of the fluid, measured the pleural effusion, and identified the optimal location for intervention. This case demonstrates how lung ultrasound complements the chest radiography by providing real-time information that directly supports patient management. For radiographer and sonographer, this highlights our role not only in image acquisition but also in providing clinically useful information to the healthcare team. And technique scanning, and then we mark the access site, the safest access site for the pleural drain. And after performing the ultrasound examination, we estimate the pleural effusion volume using COCO2 formula. So in this patient, the estimation of the volume was approximately 1.8 liters on the left side and 1.5 liters on the right side. The larger volume on the right side explains the patient respiratory symptom and supports the decision to perform drainage. Although this formula provides only an estimate, it offers valuable bedside information for procedural planning and for monitoring treatment response during the follow-up examination. Let's look at the patient imaging before and after the drainage. This chest radiography demonstrates a significant reduction in the right pleural effusion following the drainage. Clinically, patients often experience immediate improvement in breathing after removal of the large volume of the pleural fluid. This comparison also illustrates how ultrasound and chest radiography complement each other. Ultrasound guides the procedure safety, while chest radiography helps document the overall radiographic improvement after the treatment. And although lung ultrasound is an excellent bedside imaging tool, it is important to recognize the limitation. The first, ultrasound findings are not specific for tuberculosis. Features such as pleural thickening, septation, or subpleural consolidation may also be seen in emphysema malignancy or parapneumonic effusion. And the second one is limited penetration. Ultrasound evaluates only the pleura and peripheral lung. It cannot adequately assess central lung dilation, mediastinum or hilar lymph node. And then it is operator dependent. So diagnostic accuracy depends on the operator experience, a standardized scanning technique, and a proper machine optimization. And the last one, Lung ultrasound is the lung ultrasound should always be interpreted together with the patient clinical finding, laboratory result, and other imaging study. Before we conclude, I would like to leave you with 4 key messages. First, lung ultrasound offers much more than simply detecting pleural effusion. It is a valuable tool for assessing peripheral lung disease. Second one, lung ultrasound can identify sonographic features that support the diagnosis of peripheral pulmonary and pleural tuberculosis. Third, the ultrasound guidance improves the safety and accuracy of pleural procedures. And the radiographer and the sonographer play an increasingly important role not only in acquiring high-quality image, but also in supporting diagnosis, guiding intervention, and improving patient care. These recommendations are based on international guidelines and recent evidence from the organization, including WHO, and you can see here. And I encourage everyone to explore this reference for further learning and support evidence-based clinical practice. Thank you very much for your attention. I hope this session has demonstrated that lung ultrasound is a powerful, accessible, and practical imaging modality that can improve tuberculosis care across Asia. As a radiographer and sonographer, we are in a unique position to contribute to earlier diagnosis, safer procedures, and better patient outcomes. Thank you once again to the CPD Asia Organizing Committee for this opportunity. I would be happy to answer any question during the discussion session. Thank you.
Okay, thank you very much for your presentation. And dear ladies and gentlemen, tonight we would say thank you so much for Mr. Hidayat Agus Sabarudin and of course Mr. Ahmad Subarkah for our 2 insightful and complimentary presentation. And tonight we already have to explore how one disease, pulmonary tuberculosis, can be assessed through different imaging modalities from chest X-ray to CT thorax and then to thoracic ultrasound. And we will now move into the Q&A and discussion session for both speakers. For all, if you have any question, you can please submit them through the Q&A features. And now I invite to esteem all panelists to ask question and maybe engage the discussion with the speaker. Okay.
Question?
Yep.
Have a question? I can discuss. I have a question.
Yes. You can please. You can say your question here, and maybe I would like to invite Mr. Hidayat and Mr. Ahmad Subarkah first to respond these questions, and we will see their perspective from the thoracic ultrasound or thoracic CT scan or X-ray.
I want to talk with Hidayat.
Yes, of course.
Yes. Hidayat, thank you so much today. We have to speak very good topic. I have a question for Hidayat. Of course, imaging diagnosis, we very sensitive. Usually, we look for in TB by X-ray, check X-ray. Sometimes we use a low CT scanner. And we must diagnosis, right diagnosis, we must use AFP sputum. Okay, and now we have DNA like gene expert. We have a BCR, sputum the BCR. I want to ask you, before in Vietnam, we have gene expert. We look for in public gene expert first. After that, we move to check X-ray. We look for in TB in public. You know about that. Now we have many DNA. For example, gene expert, very important. Okay, and you understand me?
So sorry, Mr. Van Lok. It's mean you mean is a patient before chest X-ray. They have a laboratory first.
No, before we check X-ray screening first.
Yeah.
After that, we have some. 2 years ago, we have some research with in WHO. They use gene expert first. Gene expert, ADN, DNA, gene expert laboratory first.
Oh, okay. The
They look for
laboratory.
in TB in public. After that, we compare with in check X-ray. Sometimes the gene expert positive, but in check X-ray negative, and we must treatment for patient. I think I don't know in how about Indonesia now.
Okay, yeah. For the first time before 2022, we using the DNA laboratory first. Not using the X-ray, not using the imaging for to make sure about the TB. But at now, like recommended from the World Health Organization, this X-ray is most have to get the imaging is more better. The imaging first, then after if they have some like a suggested by radiologists, they have TB or like something like a consolidation, infiltration. So make sure going to laboratory.
Sure. Yes. I know the gene expert before 2 years ago. I have a research with WHO. Have a research within the gene expert first. After that, they move to in X-ray because the gene expert DNA very sensitive. And then before 2 years ago, I have research to get with them. Okay, and I have a question for Edmar. And I have a question for Edmar. Edmar, hello, Edmar.
Hello, sir. Yes.
Yeah, hello. I hear you say in for TB in pleural ultrasound.
Yes.
You can say clear for me. For example, patient have imaging in positive in TB positive, and then when we move to patient move to CT scanner or move to in ultrasound. Like you says ultrasound guide for biopsy by everything.
Correct.
Biopsy guide.
Correct.
Okay, right.
Yes.
Okay. You can say clear more for everybody. One patient have a TB. Okay, TB. When move to CT, when move to ultrasound. I need to clear about that.
Okay. Thank you, sir, for the question. Yes, ultrasound is actually complementary imaging, sir. imaging tool that can help detect the TB related finding, like preoral effusion and then consolidation, pleural thickening, and then can be used also to ultrasound guided procedures. So the most beneficial for ultrasound imaging is to support the safer ultrasound guided, like effusion pleural drainage. So not to become like to do the first diagnostic for TB. The first is actually chest X-ray for the imaging and the laboratory for the like a sputum or maybe a blood test, something like that. But when it is confirmed and they are like pleural effusion, ultrasound has the most beneficial to be the guided guided procedures to use with the pulmonologist to drainage the fluid, the pleural effusion. So it is cannot replace the chest X-ray to like to make it the diagnosis of the TB. Is it clear, sir? Sorry, sir, you are still on mute. You are still on mute, sir. Sorry.
Mr. Taifan Lok, maybe you're still on mute. Sorry.
Okay, thank you so much. Now we have many questions in Q&A. They'll please get in Q&A many questions. Okay, thank you so much, Edman. Thank you so much. Thank you.
Thank you.
Okay, thank you, Mr. Taifan, for your question and discussion. And to Mr. Ahmad Subarka and Mr. Hidayat, maybe we can see together the Q&A feature. This is Mr. First question is come from sorry.
From
From Mr. Vimalasena. Hello, Mr. Vimalasena. Mr. Vimalasena asking, I think this question is for Mr. Ahmad Subarkah, yeah?
Just about the ultrasound. Is it possible to use ultrasound as a diagnostic modality, as the first stage, first diagnostic modality for TB?
Okay, sir. Yeah. Thank you for the question, and the answer is no, sir. So lung ultrasound should not be used as the first line or standalone method to diagnose the TB. Yeah, because it is complementary imaging. The diagnosis of TB should be confirmed by biological tests, sputum smears, microscopy, and everything. And then for the imaging is chest X-ray. Still recommended to be the first line imaging modality, sir. Lung ultrasound have a limitation, cannot detect the deeper cavity of the chest. Yeah. So it's only for the like the superficial one, like the pleural and then the subpleural consolidation and for the effusive pleural effusion. So.
Thank you.
Yeah.
In fact, in Sri Lanka, of course, the TB is not a very few cases are available in Sri Lanka now. Only few cases are detected. But I can remember those days we used to do the MAN2 test, the MAN2 test and the chest X-ray for the diagnosis. CT was very rarely used. CT was not, and ultrasound was never used at that time. Maybe we used only the MAN2 test, that is the sputum test and the chest X-ray for the diagnosis. That is the first stage of diagnosis. The first modalities were the chest X-ray and the sputum test. Yeah.
Sir, can I ask you something about
Yes.
the ultrasound in Sri Lanka. You said in Sri Lanka, right? So, who did the ultrasound for like for the drainage, for the effusion,
Well,
biopsy, everything? Is there pulmonologist or radiologist or maybe sonographer there, sir?
well, we don't have sonographers.
Oh, you
We
don't have sonographers.
only the radiologists do the ultrasound, I think. Yeah, mostly the radiologists perform the ultrasound scans. Yes.
Okay, understand. Okay, maybe you can propose to the committee there, to the radiographer society, to
Yeah.
maybe to start to learn about how to
Yeah.
do the ultrasound, sir.
Yeah, thank you. Yeah. We have been trying, but our radiologists, they don't allow us to. Yeah,
I see. Yeah,
that's
understand.
their monopoly. Yes.
Yeah, I think that problem is in some of the another country also, sir.
Yeah.
Okay.
Thank you.
Thank you, sir.
Okay, maybe I will go to Mr. Hidayat Agus Sabarudin first. Thank you, Mr. Barka. And Mr. Hidayat Agus Sabarudin, this is a question from Ms. Pichiluna to you. On national TB programs, what is your view on having established standardized consent procedure for AI use in diagnosis? Should patient be explicitly informed when CAD is used in their diagnostic process? Wow, interesting question.
Okay. Yeah, thank you for your question, Pichiluna. I think I already answered in the chat column. Then our current view is that CAD should be implemented transparently, as a decision support tool, not a replacement for clinician. And patients should be informed that the artificial intelligence may assist the healthcare professional in interpreting of chest X-ray, while the final clinical decision remain the responsibility of qualified healthcare providers, including the radiologists, of course. And then the CAD or AI technologies, I think this is become more autonomous in the future. And consent procedure and regulatory framework should be continue to evolve in line with the national regulation, like recommended from the World Health Organization. Then at now in Indonesia, it present separate AI or CAD. Specific consent is not routinely required in Indonesia National TB Program, although the government and patient information remain very, very important. Yeah.
Okay, thank you for your answer.
Yeah, thank you.
Thank you, Pichiluna, for your question. And I want to ask to Mr. Hidayat again, why chest radiography is still the first line imaging for suspected pulmonary tuberculosis? Why don't we move to CT scan, of course, or maybe we can collab with a collaboration with ultrasound? Is X-ray still the gold standard for screening first for tuberculosis, for TB case in Indonesia?
This question for us, for me.
Yes, yeah, that's for
Sorry.
Mr. Hidayat. Why is chest radiography still the first line for imaging the suspected pulmonary TB? Why cannot we use CT scan for the first line? Why always?
Yeah, I think the CT scan is a complement when the chest X-ray is finding are inconclusive, like have a complication, maybe the complication are suspected, or finding the more detail of the evaluation of nodule of lesion is needed. I think this is CT is more more pricely, yeah. I mean, this is a more X-ray more cheaper, yeah. And then the widely can using in the rural area, and of course the chest X-ray still enough, fast, widely available, relative inexpensive, and effective an initial screening tool.
Okay, thank you. I think I will go to Mr. Ahmad Subarkah. It's still collaborating from this question. Let's see the Q&A chart box is from Nisrina Nurul Ramadhani. Nisrina Nurul Ramadhani to Mr. Ahmad Subarkah. Considering the thoracic ultrasound is highly dependent on lesion location and operator expertise. So how reliable is it as a complementary imaging modality for detecting thoracic TB manifestation beyond pleural effusion?
Yes, thank you, Miss Nisrina, for the excellent question. Yes, you are absolutely right that lung ultrasound is operator dependent and its diagnostic performance depend on the location of the lesion. So ultrasound cannot penetrate aerated healthy lung. So it is limited to detecting the abnormalities and are in the contact with the pleura or the located in the peripheral. So beyond the pleural effusion, so the lung ultrasound is reliable for identifying the consolidation, thickening, peripheral cavitary lesion, and maybe sometimes we can also find the enlarged superficial lymph node, which are common manifestation of thoracic tuberculosis. So the answer is like lung ultrasound is valuable point of care tool for detecting peripheral thoracic TB manifestation and guiding intervention. But it should not be used as part of multimodal diagnostic approach rather than as standalone test. Maybe that's my answer. Is it answer your question, Miss Nisrina?
Okay, maybe after Miss Nisrina, I still with Mr. Ahmad Subarkah. We go to Farida Hermaini, still on chat Q&A box. To what? Miss Farida Hermaini asking to you that to what extent can ultrasonography detect tuberculosis in the superior lobe segment of the lung?
Yes, very good question also. So ultrasound has low sensitivity for deep superior lobe of the lung, yeah. So the tuberculosis usually on the apex of the lung. So ultrasound has a low sensitivity for deep superior, but it is valuable for detecting the peripheral lesion that reach the pleural surface. So if there are like a consolidation or maybe like a small or subpleural consolidation and the pleural thickening, so ultrasound can detect, but not for the deep superior lesion or maybe the TB in the deep superior cannot be detected by only the ultrasound. It should always be interpreted alongside clinical finding and also with chest X-ray and laboratory tests. Yeah, I hope this is can answer your question.
Yeah, I think it's answered the question. I want to ask the Mr. Hidayat to Mr. Hidayat again. Can I call you? Okay, Mr. Hidayat, you said about the using of artificial intelligence for chest X-ray. So if the diagnosis cannot be detected by only X-ray, what should you prefer suggest to? By AI or by CT scan or ultrasound from your POV?
Pardon? Can you repeat the question, please?
Okay, if someone doing an X-ray for thorax, and then the diagnosis is unclear, so what are you suggest to by using AI still, or you go to ultrasound, or you just go to CT scan? Thank you.
If the X-ray is not clear, it's mean, yeah. I
Yeah,
think
it's
this is
mean cannot detect, the cannot diagnose. So it's maybe blur for diagnose.
okay. Yeah. The important thing about the chest X-ray is this is about the quality of the imaging. So our radiographer must be make sure the correct positioning provide accurate diagnostic image and reduce repeat examination, of course. But if the AI not working with the image, I think back to radiologist again. Yeah. But if the this is I mean the not only for chest X-ray is not clear, don't go to CT first. I mean must go to the repeat the examination first, and then if the AI or the CAD is not sure, make predict not predicted and not suggested. I think it is back to radiologist again.
Thank you, Mr. Hidayat. Very nicely explained. Is it true? Because when we are having in doubt, we can't directly go to CT scan or ultrasound. Depends on the situation. We can get back to the radiologist so he can guide. He can go through that with the expert opinion.
Yep.
Because directly going to the CT scan is a disaster.
Yep.
Because without knowing that, then something goes wrong, then entire thing is go on waste. And during the screening of TB patients also, what you told is very absolutely right. For the tuberculosis, for the screening purpose, it's a X-ray, chest X-ray is the one of the golden standard.
Yep.
For the general public. Because when you are screening out of 1,000 or 10,000 persons, maybe 1/10 or one of 100 maybe get the chances of getting TB. As you told, in Indonesia, the prevalence of tuberculosis is more. Maybe the numbers may be little increased, but with a chest X-ray, we can get a very good results and easy to identify and cheap and best. When in doubt, we can get the expert opinion, then can go to, depends on the situations, for the CT scan or ultrasound. It's the best choice. Thank you. So nice. So you've
thank you.
given a lot of data about this TB in Indonesia. It's very nice. And all can able to get that insight of that tuberculosis prevalences and how you Indonesian peoples are handling that cases. So nice to know that Indonesian situation about the TB. And
Thank
Mr. So nice. And Mr. Hidayat also given a lot of good images to explain the things. Both
Thank you.
of you given a so nice presentation. Really superb. Thank you. Thank you.
You're welcome, sir. Thank you very much.
Yeah, greetings from the ISRT India. So nice to see. Thank you.
You're welcome.
Okay, thank you, Mr. Salva Kumar, for your question. And I still with Mr. Hidayat Agus Sabarudin. This is a question for you from Miadi Lestari. Can it be determined from an X-ray whether it's newly diagnosed TB or recurrent TB? If so, what are the differences in the radiographic findings? maybe it's about acute and chronic tuberculosis. Is there any differences from the X-ray?
Sorry, your voice in my voice is up and down.
Okay. Can be it be determined from an X-ray? X-ray determine whether it's newly diagnosed TB or recurrent TB. If it can show differences, what the differences in the radiographic findings? So what the difference of an X-ray from thorax? The differences between the new TB and recurrent TB. New TB, an acute TB or chronic TB. Is there any differences from the chest X-ray?
I think this is
Sorry, I can help you.
Yeah,
I can help you. You remember 3 months ago, ASA CPD in Vietnam, we invited one Professor TP.
Yep.
He said clear for everybody. You have a positive in X-ray, positive in CT scanner or ultrasound. You must move to in laboratory sputum. Sputum like X-ray, like laboratory. You must have a positive. You must treatment for patient. Again, you have a problem. You have a problem in check X-ray, CT scanner, ultrasound. You look like a TB, but you must before you treatment for patient, you diagnosis, right diagnosis. You must have sputum laboratory or expert gene expert or BCR for diagnosis. The first. The second, see us how you different diagnosis in the new TB or on TB. I don't think so. I don't think so. In X-ray, you cannot diagnose about that. Don't think about that. You follow in clinical patient. Okay, you have a laboratory positive. Okay, you follow the patient, clinical patient. Don't think about X-ray, how a diagnosis the new or on or TB. I think that no need about that. Okay, my idea. Okay, thank you.
Yeah, thank you, Thầy Phan Lộc.
Okay, thank you, Mr. Van Lok, for adding the answer. Okay, and thank you, Mr. Hidayat, for your answer too. I would like to again invited Mr. Ahmad Subarkah. Let's see the chat box. Okay, I would like this question from Muhammad Bahrul Ulum. Okay, to Mr. Ahmad Subarkah. He said, I would like to ask question, is it necessary for radiographers to have competency in ultrasonography? Considering that ultrasound examination are generally performed by specialist physicians, what is the role and future demands for radiographers in the field of ultrasonography? Or you have any experience on it from another country, maybe?
Okay, thank you for the question, Bahrul Ulum. Yeah. So, in my opinion, yes, the ultrasonographic competency is become important for radiographer. Although the scope of the practice maybe varies between countries and institution is different, and the role of radiographers in ultrasound is expanding right now, particularly in areas where trained sonographer or radiologists are limited. And sonographer with ultrasound training can contribute in several ways, performing standardized scanning protocol, and then acquiring high quality image for interpretation by physician, and then assisting with ultrasound guided procedures, performing point of care ultrasound in specific clinical setting, yeah, something like that. And And maybe the future demand is likely to continue growing because ultrasound is portable, yeah, portable, radiation free, and relatively affordable, and increasingly supported by AI. So right now, maybe the radiographer, in my opinion, can explore more about the competency for ultrasonography. Is it answer your question?
Yeah, I think it's
Pak
answered
Lulung?
very
Yes.
complete, very complete. And again, I would invite Mr. Ahmad Subarkah and Mr. Hidayat Agus Sabarudin. Any question from Sumanti, Miss Sumanti? I would like us to both speakers, so it's question for you too. Since TB are not only occur or infected lung, it could also found in other organs as well. How would the modalities find it in other organ? Thank you.
Okay, thank you very much for your question, Mrs. Sumanti. Yeah. I think the tuberculosis indeed a systemic infection disease, and it is not limited only to the lungs. Although pulmonary TB is the most common form, approximately 5 until 20% of TB cases are extrapulmonary. And the proportion is even higher in the immunocompromised patient, such as those living with HIV. About the choice of imaging modality depend on the organ involved. Chest X-ray remain the first line imaging test for pulmonary TB. Like ultrasound, I think this is particularly useful for evaluating pleural effusion, abdominal TB, superficial lymph node, and guiding of fluid aspiration or biopsy. And about CT provide excellent assessment like mediastinal lymph node, complex pulmonary disease, and abdominal involvement. I think regardless of the imaging finding, imaging alone cannot confirm extrapulmonary TB. Definitive diagnostic still requires microbiological. I mean, this is the important thing. Not only the imaging, but the diagnostic still require microbiological, histopathological, and molecular confirmation whenever feasible, together with the clinical correlation. Yeah. This is my answer.
I think Mas Hidayat already answered the question for ultrasound, yeah. So yeah, the ultrasound is good to use for the lymph node detection, even in maybe in your neck area, and also in tuberculosis in bowel disease, yeah. And yeah, but have like a limitation because this is like operator dependent and cannot like specific like in city. So I think it is already answered, Miss Pamela. Yeah.
Okay, thank you for very nice answer, very perfect. And thank you very much for our two speakers. And maybe here, I will answer. I will give you the most important clinical pro maybe from this presentation, yeah, that imaging plays a crucial role in TB diagnosis and follow-up, but it all should always be integrated with clinical and laboratory findings for a comprehensive diagnosis, right? And then maybe from manifestation, supporting image like lung ultrasound is valuable not only for pleural effusion assessment, but also detecting peripheral TB. And it's supporting image guided tool about intervention and expanding the role of radiographers and sonographer of TB care. Okay, thank you very much. And I think our discussion here is closed. And thank you very much for Mr. Hidayat and Mr. Ahmad Subarkah for your thoughtful answer, insight, and valuable discussion. And We have learned a multimodality approach tonight to pulmonary tuberculosis, so we can provide a more comprehensive perspective, while radiographers play an important role to ensuring that imaging examination are performed appropriately, safely, and of course with high quality. Once again, thank you to both of our speakers tonight for sharing time, knowledge, and expertise. Ladies and gentlemen, this brings our scientific presentation and discussion at 64 CPD Asia to the end. And I would like to hand over again the station back to Ms. Pichuluna. I like to, for the invitation and announcement, the upcoming of the next CPD Asia programs. So Ms. Pichuluna, well, I give you back the floor. Thank you.
Thank
All right.
you. So nice.
Thank you so much, Pamela Puspa, for that great moderation of the session. Ladies and gentlemen, as we come close to the end of this enlightening session, please allow me to extend our deepest appreciation to our distinguished speakers, Sir Hidayat Agus Saburuddin and Sir Ahmad Subarka. Thank you so much. We also extend our gratitude to our panel members who have joined us, to our presidents who were here live. And before we part, we are delighted to invite everyone to continue this journey on learning with us at the August CPD Asia session. To give us the invitation, I'd like to call Miss Alice Chang from TAMRT Taiwan.
It's my pleasure to invite all of you to our next CPD Asia session, so which will be hosted by the TMRT. The next CPD will be held on Saturday, August 15, 2026 from 1 p.m. to 2:30 p.m. So we have prepared an exciting program featuring 3 presentations on artificial intelligence application in medical imaging. So we sincerely invite all of you to join us. So registration details will be available soon. So I look forward to welcome you all online. Thank you.
All right, thank you so much, Miss Alice Chang. Again, we'd like to express our deepest gratitude to PARI, to President Dr. Yek Subianto, to our speakers, to everyone who have joined us here and made this successful event. And we'd like to save that date also. Again, thank you, TMRT, for that warm invitation. We would like to say thank you, Pari. We will meet you again next month. And thank you, everyone, for joining us here today.
Okay, thank you, Pichi.
Thank you, everyone.
Yeah, thank you,
Bye-bye.
everyone.
Thank you.
Thank you.
Thank you. So
All
nice.
presidents.
Thank you.
Yeah.
Bye.
Thank you.
Thank you. Bye-bye. Thank you.
Thank you. Bye-bye.
Thank you, everybody. Thank you. Goodbye.
Thank
Goodbye.
you so
Bye.
much.
Bye.
Welcome to Yogyakarta, the cultural heart of Indonesia, a city where tradition, heritage, and modern life come together. Yogyakarta is easily accessible through Yogyakarta International Airport, connecting visitors from across Southeast Asia. Through music and performance, Yogyakarta celebrates the harmony between tradition and innovation. Home to one of the largest Hindu temples in Southeast Asia, Prambanan stands as a symbol of history and architectural excellence. experience the legendary Ramayana Ballet, where culture, music, and storytelling come alive under the night sky. From generation to generation, Yogyakarta continues to preserve its cultural heritage through art, craftsmanship, and daily traditions. We look forward to welcoming you to Yogyakarta, where culture inspires, heritage lives, and friendships begin.